Good afternoon and welcome everyone. My name is Robin Buxbaum and I'm the Strategic Partnerships Coordinator here at ACHA. This is our fifth ACHA COVID-19 webinar discussion. We've covered several topics now that are applicable to our members. Recordings of all of our Q&A discussions are available on the ACHA YouTube channel. For those looking for specific assistance with health promotion, the health promotion section is holding weekly Zoom chats, and those are open to any interested ACHA member. As another reminder, for all the latest updates, continue to check the ACHA COVID-19 website. At any time today, feel free to type a question into the questions pane on the right side of your screen. We will have some time at the end for Q&A. Although we may not get to all questions today, we do review that list after each webinar and have been incorporating those into our FAQ document on the ACHA COVID-19 webpage. One last item, those registered will receive a link to a recording of today's presentation, but it will also be posted on the ACHA YouTube channel. With that said, let's get going. Today our session will be moderated by Jerry Taylor. Jerry is a member of the ACHA COVID-19 Task Force, and she co-chaired the COVID-19 Survey Subcommittee. She's the former Associate Dean for Health Counseling and Health Promotion and the former Director of the Health Center at Bentley University. I'm also pleased to introduce our four other speakers today. Anita Barkin recently retired after serving as the Deputy Director of Georgia's North Central Health District. Prior to her work at the Health District, she served as the Director of University Health Services for Carnegie Mellon University. She is a former president of ACHA and currently serves as one of ACHA's COVID-19 Task Force members. Anita has been recently appointed to the Board of Directors for the Healthcare Georgia Foundation. Dr. DeMaria is a medical and laboratory consultant at the Massachusetts Department of Public Health, where he previously served as medical director of the Bureau of Infectious Disease and Laboratory Sciences, and for many years, state epidemiologist for Massachusetts. He currently serves as the president of the Massachusetts Infectious Disease Society and is a past president of the Council of State and Territorial Epidemiologists and the Northeast branch of the American Society for Microbiology. Angela Long is the Director of Health Initiatives at the University of Oregon University Health Center. She is responsible for health information systems and information technology, health promotion, compliance accreditation and medical records, marketing, communications, assessment, and the UO immunization compliance program. Before joining the University of Oregon, Angela worked for the University of Wisconsin University Health Services and at the U.S. Pharmacopoeia, a standard-setting organization for medicines, dietary supplements, and food. Annette Smytch is a board-certified family nurse practitioner and school nurse. Annette has been working at Seton Hill University in health services for 4 years as a clinical provider. She has also worked in health services at Carnegie Mellon University and Duquesne University. In addition to working in college health, Annette volunteers at a faith-based clinic that provides free medical care to individuals who are uninsured. So first of all, welcome to everyone, and thank you for joining us. I'm going to turn it over now to Jerry to kick us off.
Thank you so much, Robin. As Anita will discuss in more detail, our survey results communicated to us that your biggest concern right now is related to reopening campuses. The COVID-19 task force is busy at work creating guidelines to help you, and we anticipate those being released in the next 2 weeks. As part of those guidelines, a critical piece of that involves working with your local and state health departments. But what does that look like in practical terms? Today, we're going to explore that topic and hopefully provide you with some answers to your questions. First of all, Anita will briefly discuss the ACHA COVID-19 snapshot survey and how those results are informing our efforts to help you. Anita?
Good afternoon, everyone. As Jerry has indicated, we did start collecting data in order to provide some information, benchmarking data for our members, and also so that we can document as much as possible how campuses were affected and have responded to the pandemic throughout. So while we issued our first survey April 6th through 9th, we are already starting to talk about a follow-up survey to take another snapshot of what is happening on campuses as we work our way through this pandemic. Our methods were to just send this online request to our member institution representatives. There were 728 individuals who received this request, and we had a response rate of 52%, and which resulted in about 380 usable surveys, which is a pretty remarkable response. For those of you who do surveys, I think you can appreciate that 52% was a robust response. Predominantly four-year institutions responded, and nearly half were in urban settings, but we had a nice representative sample from across the United States, with all regions pretty equally represented. We had fewer schools in the western region of the country, but overall a nice representation and distribution nationally. There were schools, historically Black colleges and universities represented, and related schools were represented. So we were pleased with the sample size. What we noted as we analyzed the data is pretty much consistent with what we believed was happening from all of the anecdotal information we were receiving from members. In that there was a dramatic shift in the way that campus operations were being conducted. We noted a significant transition to distal virtual learning strategies and decompression of residence halls. There was a significant move to telemedicine, telecounseling, and telepsychiatry, which happened very quickly and represented great challenges because schools typically did not conduct business that way. We're in the kind of person-to-person kind of delivery of care. However, this necessitated moving to a different method of providing those services, and that certainly was represented by a high number of responses. There's also decompression of on-site service staff and mental health and health promotion services. In the health arena, we saw people were working remotely, but there were also some members who were working on site as well, with a limited number of person-to-person visits being accepted. In the mental health arena, it was almost totally telepsychiatry and telecounseling, with very, very few people reporting that they had staff on site. Health promotion was another example where almost all services that were being provided moved to moved from on-campus provision to online provision of those services, and those staff members were working from home. We looked at testing, how many schools were testing for COVID-19 on campus, and 28% of the responding schools had indicated that they had initiated testing. Those schools were predominantly larger institutions that were providing testing in the health services area. A few were doing some off-site testing. The majority of responding schools reported having access to adequate PPE at the time that the survey was administered. And I think that's a really important point to remember, because when this survey went out, we have to remember that we had decompression of the residence halls, significant decompression, with 87% of responding schools going with distal or virtual learning, and very few schools indicating that they had unrestricted access to their residence halls. So the number of folks coming into the health center that would require staff to be suited up in PPE would be a very small number. What that looks like in the fall may be an entirely different story. At the time that the survey was taken, again, 40% felt that they had adequate testing supplies in order to do COVID-19 testing in a safe manner. So again, what this looks like in the fall may be very different if colleges or universities make a decision that they're going to try to initiate an on-campus experience for their students. I would encourage you, we don't have time today for me to go into all of the particulars and all the statistics related to these different topics. The full report is available on the ACHA website, and I would encourage you to access the report online. And it's very easy to read, lots of charts and graphs, and you can get a real sense for very quickly for how dramatic the shift was in the landscape of college health. So looking ahead, as Jerry said, at this point, many schools are focused on what happens in the fall. And so that is a major concern that the task force certainly has recognized and is working hard on a plan to try to address some of the issues that we have that have been raised by members. So what will be the expectations for health, mental health, and health promotion services in the fall? What will that look like depending on how your school decides to respond? Will local public health departments be available to provide support? Will local health departments perform testing, or will the on-campus health service be expected to do so? If you remember, I said 28% of schools indicated they were doing testing. It was 106 schools out of the respondents were doing some testing. Well, what will that look like in the fall? If you haven't decided to do testing, will you need to pick that service up and provide those tests? And then what is the relationship with the local health department related to testing your on-campus faculty, staff, students, the population you serve? And will the health department provide testing materials to student health? Who will assume the role of contact tracing? Will that be your responsibility? Will it be public health responsibility? And I think the thing that we have to remember is public health departments will be strained. They have limited resources, and so the response could be very different from one community to the next. If a vaccine becomes available, will the local health department administer the vaccine to the campus community, or will student health services be expected to take care of vaccinating their campus community members? So how does that play out? Will the health department acquire the vaccine and then distribute it to the campus community? Will student health services be expected to order vaccine indirectly? All of those questions beg a better understanding of what our relationship will look like with our local public health departments.
Thank you, Anita. Next up is Dr. DeMaria, who will give us a statewide perspective on COVID-19. Dr. DeMaria?
Thank you, Jerry. It's a pleasure to join you today in this webinar. Over the years, I've come to really appreciate the work that you do and the challenges that you face. I'm going to talk, first I'm going to talk about some things that I think you already know, but I think it's worth sort of revisiting as you start to think about interacting with the health departments. And the first thing is that in the United States, the public health is not in the Constitution. And that means it falls under Article 10, which means it devolves to the states. And although we tend to think of CDC and Tony Fauci as representing public health, all public health is local. And even on the state level, public health is usually done at the county or municipal level. And so, for example, surveillance, people look to the CDC for numbers of cases. They look to the state for a number of cases. And in many instances, all of this surveillance is going on at the local level. And so it's really at the local level that surveillance is done and disease control is done. So when you interact with the health department, you're really going to be, in the majority of cases, interacting with a county, a city, or a local health department of some jurisdiction. So that's important to keep in mind. We still have situations where universities, this is not the health services, usually university researchers go directly to the CDC and they get told, no, we can't enter the state, we can't get involved in the state without an invitation from the state health department. So it's always good to recognize all public health is local. Next slide. And what are these localities? The over 3,000 counties in the United States. In most of the United States, it's the county that is the public health jurisdiction. And often that involves not only public health surveillance, disease control, public education around public health, but it also involves delivering clinical services as a safety net for people who can't get care elsewhere. So there's a mixture of services presented or provided by the county health department, functioning as a local health department. Now that varies greatly. Next slide, please. This sort of represents, we live in a federal system, so every state is different and every state does things differently. And even within states, the local health departments are different. They're structured differently. In Massachusetts, every city and town is a public health jurisdiction. So we have 351 independent boards of health. And that's 12% of all the local health departments in the United States because we don't have a county health system. So that's a peculiarity of Massachusetts. But if you go around the country, you can see some states have independent, decentralized health departments on the county basis or even on the big city basis. Some have districts, some have county health departments organized in districts. So you really have to know who your local health jurisdiction is, what it is, and interacting with it. And I'm sure you've interacted with your local health departments on many occasions for many purposes. But you have to keep in mind that that's just because COVID-19 is a national emergency and a state emergency in many states, it's still the local health department that is going to be dealing with you and with COVID-19 as we go through this and even currently. Next slide. And CDC doesn't miss this. You're in there among the educational institutions as a very important part of the public health system. In this instance, they're also including public education at the elementary and secondary level, but colleges and universities are recognized as critical entities in dealing with public health issues. Next slide. And if you look at what you do and what a health department does, there are a lot of, there's actually at least one mistake here, but there are a lot of commonalities. The check marks somehow got shifted around. But so let me explain. The college and university health services are responsible for a population, while the health department is responsible for a population, and those populations obviously overlap and are superimposed. There's a mistake in the next slide. You have a contractual and employer relationship with your population. So your responsibility and your authority is based on that contractual relationship. Whereas the health department has legal authority over its population, legal authority that you do not have, so that you can tell your students, faculty, and staff that they have to isolate, but you have no way of enforcing that legally. The health department can enforce that legally. You have certain contractual obligations to your students that might complicate your ability to quarantine or isolate them. The health department does not have that contractual relationship to deal with. On the other hand, both need data, and when you start to think about, and well, you've already been thinking about this relationship with the local health department, it would be very valuable to look at how you capture data and what data you capture. Because if you think back to your experience with mumps, measles, tuberculosis, invasive meningococcal disease, norovirus, whatever, you're often sharing data with the health department. To the extent that you can figure out a way that can be done expeditiously, is going to be highly advantageous no matter who does what in terms of identifying cases, doing contact tracing, doing isolation and quarantine, and ultimately vaccinating. Because whenever we're going to vaccinate people against COVID-19, we're going to want to have data systems in place to know who's been vaccinated, who hasn't been vaccinated. And even when we start to do antibody testing, whether it's before or after vaccination, think to situations where antibody versus vaccination is important data to have. So that should be something we should be thinking about now. And then an appreciation for the resources that are going to be necessary. I know a big question here is who's going to do what in terms of vaccination. I think it's highly unlikely that the local health department is going to come on campus to vaccinate. So I think you need to be thinking about vaccination campaigns on campus that leverages all the resources that you have. So that resource allocation has to be part of this, and you have to communicate at some point. And it's difficult now to communicate with the health department. I know I spend all day long communicating with health departments in Massachusetts and my own health department, and it's hard. It's hard to get time and attention because they're flat out at the moment. But hopefully, when the curve is depressed and we're moving on to the next phase, that those lines of communication will become much more efficient than they are currently. Next slide. So as I said, you have already done this. Almost everybody on this call has had some kind of experience, either personally or institutionally, with the local health department, because these things come up all the time. Mumps, norovirus, meningococcal disease, measles, and a variety of other foodborne outbreaks, outbreaks related to exposures on campus. We've had interactions around Legionnaire's disease related to airborne sources on campus. Everyone has had, over the years, has had some experience dealing with disease or an outbreak that involves the local health department. And it's not going to be any different with COVID-19. It perhaps will be more intense. It'll be more complicated, I'm sure. But if we start to think about how to make this easier, we start to think about our experiences in the past with dealing with these issues, it will help to inform. I think sometimes we think of COVID-19 as totally new, totally inexplicable, something totally new. But when you start thinking about the issues you're facing with COVID-19, those issues tend to be the same issues we've always dealt with with these other circumstances. And it's going to be the same way when we start thinking about vaccination, because many of you have had to do vaccination campaigns, whether it's for measles, mumps, or meningococcal disease in the past. And it's not going to be any different. Next slide, please. And also, remember that the health department is involved, and I already alluded to this. The health department has a lot of other functions, and those functions may be prioritized in different ways with COVID-19, but they're never going to go away. So I think the less you expect from the health department, the more you're going to be delighted in what they can do for you. But I think you have to start from the standpoint that the health department is a complicated organization that has a lot of other things going on. And next slide. And the infrastructure may not be what it's supposed to be. So that I think we all recognize that our investment in public health perhaps has not been optimal over the years. And now with the stresses of COVID-19, we have to really figure out how we can work together to leverage what we can do in the best possible way to accomplish what has to be accomplished. Next slide. And you know, some of the things that have come up already in Massachusetts, our first cases and our first suspect cases were on college campuses. And the question came out where to put sick students. And, you know, health departments don't have places to put people. Now, we've developed some in response to COVID-19, but the question is what will be there in the future. If you're not going to be on campus in the fall semester, in the spring semester, I don't think even by the fall semester we will still have the capacity to house people under different circumstances. So that's going to be a problem, and it came up in our experience in terms of what do you do with the roommates, where do you put the students, where do you quarantine, if the student's off campus, what happens to the student's roommates, and those kinds of things are going to come up again. And I think you should not expect that if your health department has space, that's wonderful, but don't expect it. Who does a contact investigation? I think that's also, I think the health department is going to feel the responsibility to do the contact investigation. Now, this has already come up in healthcare facilities, and arrangements have been made between the healthcare facility and the health department to maximize their resources on both sides by having the hospital or the healthcare facility do the contact investigation within their facility, because they have all the information they need to share it with the health department, and then to be told what they have to do didn't make any sense. And I think we could sort of figure out ways that that's going to happen between the colleges and universities and the health department. Where to put contacts? There's no good answer to that. I don't think any health department is going to have a place to put contacts. People are talking about it, but I think in reality, it's going to be a hard thing, because these are healthy people who are not sick, are going to be asked to leave their homes, leave their families, leave whatever to go someplace. It's not going to be an easy thing to do. And the roommates I've already alluded to, those roommates, you know, we may be talking about students living off campus. We may talk about totally filled dormitories at some point, because hopefully we're going to get back to normal. And if we're going to still have endemic cases, we're going to have to do contact tracing and quarantine for those. The other question came up, who pays for room and board for cases and contacts? Health departments don't have those resources now. Now, it's possible that those resources might become available at some point for certain sectors of the population, but I think it's going to go for people who have absolutely no resources of their own to self-shelter. So we're looking at room and board for people who are homeless, people who are otherwise compromised in that way. Who enforces quarantine and social distancing? I think on campus you have a lot of leverage to say you can do this, you can't do that. but the health department has even more leverage because they can have legal authority to quarantine people at least. Social distancing, you know, people said, well, we should mandate social distancing. Well, who's going to police that? That's not, you know, it's not going to be, nobody's going to have the resource to keep an eye on everybody who shouldn't be talking to each other. So I think we have to figure out how we're going to do that together, public health and higher education. How to manage release or isolation has become extraordinarily complicated because we have a symptom release. If you're better at now, it's going to be 10 days. If you're better at 10 days and you've been well for 3 days, you can be released. And some of those people are then going to get tested and they're positive. And that's no surprise. We knew they were going to be positive in many instances. That wasn't the basis of that release. So hopefully by the time it becomes an issue for college campuses, we'll have that figured out. But right now, it's very difficult because once people are positive again, they're put in isolation for another 7 days, even though if they hadn't been tested, nobody would have known the difference. So that's complicated. What are the confidentiality parameters? What can you share with the health department? I think you need to look into that now versus later. What information, because it varies by jurisdiction, it varies by what your lawyers tell you, and it's good to have all of that worked out now before you need to know about it in the real situation. And we're all going to have to deal with asymptomatic infection. More we're learning, we're learning that people are walking around who are totally well, who would never be screened out in any kind of clinical screen, who have SARS coronavirus 2 in their airway. They're breathing it out. They're contributing something to transmission, not as much as symptomatic people, but something. And you need to start thinking about what the implications are. Well, everybody tries to figure out what's going to be done about this, because I think it's going to be something we're going to have to deal with right away. And we're going to have to start figuring out if we want to really keep a lid on COVID-19 transmission. And I think what it means is masking and some degree of social distancing into the future until we have a vaccine. In terms of vaccine, I've already mentioned, I don't think you should rely on the local health department to vaccinate. I don't think that's going to be within their capacity, because there'll be expectations they'll be doing big vaccination clinics for the public and in the schools and so forth. The PPE supplies, I think now you can get on a list for PPE supplies. I think right now probably university and college health services are not on that list as far as I remember, but I think that needs to be dealt with. And let me finish there, because I'm much more interested in the other speakers and the questions.
Thanks so much, Dr. DeMaria. Now we're going to hear from Angie Long, who will tell us how the University of Oregon is working with their local and state entities. Angie?
Well, thank you, Jerry. And I'm just delighted to be here to talk with you about our interactions with public health departments. And I have to thank Dr. DeMaria for really teasing out what you see here in this slide. This is not my own slide. You've probably seen it before, but we really believe that college health is public health. And we're looking at a community. And so our population of students is equal to a small city. And so we do treat a population in the community that they live, learn, work, and play. And we do hope that someday we'll be back to what you're seeing here in this congregate situation. But on the next slide, I wanted to tell you just a little bit about the University Health Center here at the University of Oregon. It's multi-specialty with primary care, acute care, psychiatry, endocrinology, and ancillary services, dental, physical therapy, pharmacy. We have our own laboratory and x-ray department, a separate wellness center, and 150 staff members, 20 of whom are providers. And about 50% of our students access the health center. We have a separate counseling center, not within the University Health Services, but we're in the same building. And you can see our new building that we're going to proudly open in a few weeks. So we have additional space. And I will add here that we opened up a separate entrance for respiratory patients and have a dedicated clinic during COVID-19. Next slide, I'm going to start getting into our interactions with our health authorities. And as Dr. DeMaria indicated, we have a state public health authority that is used to be under the Department of Health and Human Services. It came out from under that, has many divisions. It's a large organization, and we work primarily through the Center of Public Health Practice, and there you see communicable disease prevention and HIV, STD, and tuberculosis section and immunization section. And they are located in Portland, which is our largest city, but not our capital. And as Dr. DeMaria said, we work with them. They're a good resource for us, but they do tend to have us go directly to our local public health. But on the next slide, I will tell you a little bit about how we typically interact with them. We have a state law that requires measles vaccination, and they help us with our vaccine requirements and tuberculosis screening requirement. Obviously, they're working with us on communicable disease reporting, our required reporting, and outbreaks. We did have a MenB outbreak in 2015. They are great resources for us on our mass vaccine clinics, and especially with transport and storage of vaccines, and getting into the VFC program for special clinics at which we can be prepared for emergency mass vax clinics, and also benefit from the vaccines at no cost to our students or us. And they're always advising and counsel for us on special topics. They have an annual epidemiology conference that is also excellent. It didn't happen this year though. So on the next slide, here's how we're interacting with them during COVID-19. So they provide bi-weekly calls for clinicians for resource information, and weekly calls for health communicators across the state. I'm participating in those calls, and they have updated talking points, and which are very helpful. They push emails, including the case counts and deaths each day, and give us good weekly epidemiological reports that gives us an idea of the symptoms that Oregonians are experiencing in this pandemic. And they have state laboratory support, and as with everybody else, I'm sure they were the only game in town until early April, until others labs came on board, and now they're testing individuals in congregate living at the state lab. So that's a speedier way to get results, and advice and consultation. Let's go to our local public health department. You can see here that we have a county health department. It's located in the same city where the university is located. It's under the larger Health and Human Services department. And then let's go to the next slide. How we typically interact, we are strong community partners, and they support us in every aspect of what we do, from vaccine requirements and perspectives there, communicable disease, our mass vax clinics, and our direct contact for the VFC program. We participate on their committees, and we even have student internships that offer learning opportunities. And of course, we have cell phone numbers of our senior public health officer. That's how close we are in collaborating and getting their advice and consultation. On the next slide, during COVID-19, our health department, our local health department did a great service to, I think, eliminate those cell phone calls, but they have had daily calls for clinicians and other medical professions for an hour each day, 5 days a week. It's now gone to 3 days a week, but 6 weeks of that. And we were able to ask our questions there, get daily information, hear guest speakers that they brought in, get testing updates and PPE supply updates. and they have an opportunity for individual or health centers that need supplies to resupply them. They have a call center for the community and daily case updates, again, press briefings, social media, website updates, and this is really invaluable to us. And we also reached out to them on isolation. On our next slide, I just wanted to briefly indicate that we have a campus incident management team, a lot of participation across the campus. But what I wanted to share here is that in addition to University Health Center representatives, there are several IMT members who are interacting with our state and local public health departments as we move through our different phases of responding, recovering, and reopening the university. And then on my last slide, let's talk about reopening a little bit. This week we received a letter from our president. I think he's actually even talking on CNN right now as we speak, but that we intend to open in the fall in person on campus. And he was strongly emphasizing that it won't be the same. And, you know, what are some of the initial things that we're thinking about as far as how will we do it? The university itself has increased testing capacity in the community. We've partnered with a local hospital on a testing machine that's really making turnaround times just go faster. We're working on a research project on a screening of students in our residence halls. We're potentially assisting with contact tracing through students, potentially. And then considering influenza vaccine requirement for this fall, and ultimately figuring out how to do a mass vax clinic for the COVID-19 vaccine. So I'll stop there. Thank you.
Thank you, Angie. Now Annette is going to give us some insight into what a one nurse health center looks like in comparison to a larger university that's well resourced. Annette?
Thank you, Jerry. Good afternoon, everyone. I appreciate hearing your experience, Angela, at a large university. I think you will find my experience at Seton Hill very different. Seton Hill University is a private Catholic university in Southwest PA with a total enrollment of approximately 3,100 students. We have about 1,500 traditional undergraduate students, and of these, 55% are residents. Health services is staffed solely by a nurse practitioner, which is myself, and we have one exam room. Our current stock of PPE is minimal. Unless you are on the supplier's allocated list to receive PPE, your order is canceled. To be on the distribution list, that specific item must have been ordered from the supplier in the preceding months. In fairness to the local health department, the challenges we experienced spanned a short time frame. The first case of COVID-19 in Pennsylvania was reported on March 6th. A couple weeks later, Seton Hill transitioned to online classes and most students returned home. However, prior to this transition, it was very difficult to get COVID-19 testing approved. Most, if not all, criteria needed to be met. I did see a patient who presented to health services with a fever. I believe it was around 101.2. He also had a cough and shortness of breath. He had been seen 3 weeks earlier for influenza-like illness and was treated with Tamiflu. However, he reported that his symptoms never fully resolved. I contacted the health department and was advised to do a culture for pertussis first, because I was told that the county was seeing an uptick of pertussis. I was told if the pertussis culture was negative and if the student was still symptomatic, then to call them back and they would reevaluate to determine if COVID-19 testing was necessary. Fortunately, I didn't have to get to that point because the student's symptoms resolved. So I was happy about that. Another challenge that we find at Seton Hill is a lack of resources on the weekend. I suspect most places the local health department is closed. And if you do call the local health department on the weekend, You receive a message on the answering machine that will direct you to the Pennsylvania Health Line. However, this is also a recorded message. So to date, I have not had any success talking to a live person on the weekend. One resource that has been very helpful is I have been in contact with a larger neighboring county health department. They have been a tremendous resource in offering guidance. With this particular health department, you can also sign up for daily text messages and email alerts, updating on the current COVID-19 situation, and I have found this to be extremely helpful. Next slide, please. So in light of the public health challenges we have been facing at Seton Hill, we have been looking at the CDC, World Health Organization, and ACHA as key resources for guidance. In addition, we have started conversations with local universities on reopening plans. Now I would just like to discuss some health service strategies that we have been talking about. So the first thing is, at a minimum, I think it is important to have an additional exam room. Ideally, we would like one room that we could reserve specifically for suspected COVID cases, or even I suspect in the fall we're going to be seeing influenza cases. So a room for flu and COVID, and then a room for all the other visits. Also, we are anticipating an increased demand in healthcare services. Therefore, adding another staff member and expanding clinic hours will allow us to accommodate and support students. As far as COVID-19 testing, in order to better serve students and expedite diagnosis of suspected cases and provide continuity of care, at this time, I am recommending that we do test for COVID-19. I have discussed this with our local health department. They also agree that it would be prudent. However, this recommendation is contingent upon obtaining proper PPE and additional space. If we don't have these measures in place, I don't think that we will be able to do it, because safety is, foremost and paramount. We have been working with trying to secure extra medical supplies, such as no contact thermometers, extra nebulizers. We have been collaborating with the purchasing department on sourcing PPE. We are also in the process of ordering additional over-the-counter medication. We are anticipating that the students that we are going to be seeing will not be able to get out to the pharmacy. We do give students a small starter pack, but we are expecting that we will need to increase the amount of over-the-counter medications that we give them. We do have a local pharmacy that will deliver prescription medication to campus, and we have contacted them, and they have agreed that if they are delivering medications for a student, that they will also add on over-the-counter medication if the student needs that as well. Currently, we are doing telehealth visits for students who remain on campus. We do plan to continue doing this at home. We plan to keep doing this in the fall. We want to keep students safe from possible exposure to coronavirus. So if it is at all feasible and prudent, we would like to continue to implement this practice. We will continue our communication with the local health department. At this time, contact tracing is just being introduced into smaller Pennsylvania counties, but it is not being done locally, although this is expected to change. When I have been in contact with the health department, they said that they will be able to assist us with this process, and they are anticipating by fall that they will become experts. And, at this time, it doesn't seem like this will be a problem getting their assistance. And also, of course, as I mentioned, our larger neighboring county, although they cannot approve tests for us, they have been very helpful in providing guidance, and will be continued to be a valuable resource going forward. Next slide, please. So outside the Health Service Department, there has been university-wide reopening conversations multiple times each week. We have a reopening committee. It consists of senior administration from various disciplines who are brainstorming and considering various scenarios and sharing back to their respective departments, who is further discussing the topics that are under review. Because our local health department is small and overtaxed, we do have limitations on expectations for assistance. We have seen that in the past just from other experiences. And as I mentioned, our local health department is a very small department. They do have multiple responsibilities. I know that they do not get a lot of funding. So, we are aggressively looking outside for assistance and guidance. As I mentioned, the reopening committee, some things that they're doing, I have listed below in the bullets. As far as academic class adjustments, they're looking at smaller classroom sizes, offering more sections, maybe having the students wipe down desks before and after class. The reopening committee is also discussing how they would quickly convert to online classes if needed. The committee is also looking at housing options. Specifically from a health service point, I look at, how are we going to support students who are COVID-19 positive, or how do we support students while we are waiting for those tests to come back? At Seton Hill, dining is a concern because we have just one main dining hall, and this is also a significant social hub for students. So conversation has been centered around reconfiguring the seats, removing chairs, possibly removing self-service utensils, were just some ideas that were thrown on the table. Also, the committee is looking at recommendations for cleaning, possibly increasing the cleaning of the bathrooms, the common surfaces, the common spaces, perhaps removing shared lounge furniture. We do have some residence hall where there's a community kitchen, perhaps removing shared utensils, pots and pans might be something important to do. Another idea that has come up has been perhaps locking down larger space. This is maybe like at 9 o'clock instead of keeping them up open all night, shutting down earlier. And finally, we are also looking at guidelines, considering guidelines for how employees will begin to return to work. The committee is considering items such as, employee screening stations. How do we accommodate for employees who are vulnerable and have pre-existing medical conditions? The goal is we just want everybody to come back safely, and these conversations are fluid and ongoing daily. Every day, like you all, you're reading the CDC and trying to keep updated. And, as we continue to receive new updates from our key resources, we are rethinking our strategies so that we can provide the best and safest practices for our campus community. Thank you.
Thank you so much, Annette. Now a few questions I want to address that came through on the question board. One was the survey sent to just institutional members. Yes, it was. We are correcting that with the second survey, and we'll be sending out to one person from each college. So stay tuned. Hopefully you'll be able to get a survey next time around if you did not this time. I wanted to ask Dr. DeMaria, is there one test that is the best that we should be trying to use at the colleges?
Yeah, I know there's so much attention towards testing, and the best test we have for actual infection is some form of nucleic acid test. Usually it's a real-time PCR test. It's used in all the public health laboratories and most of the commercial laboratories. There are some variations on this that are available. One that's now FDA approved and actually can be done in a CLIA waived fashion is the ID Now, the Abbott ID Now. But there'll be other such tests that'll bring sort of more rapid testing available to more places. The other thing is there are a large number of antibody tests that are sort of flooding. I don't want to say flooding the market because they're just flooding. And a lot of them have been examined and found wanting. So I would be very careful about any antibody testing you do. It's not diagnostic. You can't say that somebody is actively infected with the antibody test, but it might become useful in the future as we go forward. And be just very cautious about what antibody tests you access, even later, because I think it's just going to be very confusing to get these tests and interpret the tests. The other thing that is coming up more and more now as we clear people on clinical bases is that people get retested and are positive, and people can be positive for up to weeks after they're recovered and they're being cleared. So we need to come up with a way of figuring out what to do with these individuals that is consistent across the board. So
Dr. DeMaria, we've also had the report that 30% of the tests give false negatives, and then should people then retest a couple days later?
No test is perfect, and that 30% false negative, I think, is based on Chinese studies where a CT scan of the chest was used as the basis for a COVID-19 diagnosis, and I would question whether everybody who's sick who has a CT scan under those circumstances, that is a CT scan is abnormal, had COVID-19. So I think, you know, when we look at these PCR tests, they seem to have a very high sensitivity and specificity. And the key element to whether they're going to be false positive or false, well, whether they're going to be false negative is the quality of the specimens submitted. So nasopharyngeal swabs have to get into the nasopharynx. I think we're learning more about other samples that could be used, like nasal swabs, even self-collection of specimens. But the specimen has to be sufficient and satisfactory for the test to be reliable. So that's another factor here.
Great. So I'm looking at a couple of the other things. Social distancing on a college campus. I'll ask Dr. DeMaria first and then see if the other panelists have comments on that. How do we do that with students so close together with shared bathrooms, et cetera, et cetera?
Yeah, it's going to be enormously difficult. I think it's not in the nature of the population you're dealing with to stay apart. And, you know, I think everybody on this call knows much more about what that involves and how to do that than I would.
Any other panelists want to address that? No? Okay. Anita?
Jerry, this is Angie. I'm sorry,
Sure.
I was struggling with the mute button. You know, I think that that's one of the biggest questions facing, you know, a large university. And just this morning on our IMT meeting, we heard from our campus GIS and mapping program that's been involved with actually doing spacing models for our academic learning areas. And so, you know, we're actually calling on the resources within our own institution to look at how that needs to be going forward.
Okay, thank you. And some larger schools may be able to do something like that. It still is going to be a very difficult problem, I think. We are coming close to the end of our time, but I've been told we could go a little bit over if people can stay with us, just so that we can address a few more questions. Let's see. screening. People have said, some are saying that they're taking temperatures of staff 2 or 3 times a day. Is this something other colleges are doing? How about you, Angie?
Yeah, thank you for that question. We actually instituted a temperature screening station staffed by our MAs at our main entrance several weeks ago. So that's for everybody coming into the health center. And we also have our counseling center, and we have a testing center in the building as well. So that's for every patron or anybody who is accessing our building for any reason, and they get, a thermoscan of their temperature and are asked about symptoms before they're allowed to go forward. We have big stop signs to help with that. On Monday, we're actually implementing a staff screening process, and we had to sort of back up the time for that and staff it accordingly because several people enter the building starting at 7 o'clock in the morning. But that will start on Monday, and for all staff. So anybody entering the building will have their temperatures monitored.
And that means all medical staff, is that correct?
Yes.
Or do you mean, okay, not for the
All
rest
staff.
of the college?
Correct.
Now, some colleges are looking at masking everyone on campus, whoever comes on campus. Some are even branding those masks. Dr. DeMaria, what do you think of that?
No, I think, as I said, we don't really understand about pre-symptomatic and asymptomatic individuals. We assume they're much, much less infectious than someone with symptoms. So we're never going to, we obviously have to look out for symptoms and isolate people who are symptomatic. But I think the only way really to address asymptomatic is for everybody to wear a mask, because if this, even more for preventing transmission than even preventing acquisition. So I think that's going to be something that we're going to have to come to some conclusion about before too long.
Thank you. Any other comments on that from the panelists?
Hi, this is Annette Smytch from Seton Hill. If I may say, we actually, these are exact conversations that we are also having. We have been looking at masks for everybody, for employees, students, just to protect each other. And
Yes.
so that has not been finalized yet, but also we have been having a lot of discussion about self-screening stations. Actually, it was on the listserv. There was a university that actually developed a COVID employee screen checklist. And so we've been having conversation about, employees taking ownership and responsibility for performing the self-screen, prior to coming to work, and then if we had vendors or, visitors coming, then, having self-screen stations there for them to do the checklist. So these are ongoing conversations. So we're looking forward to guidance from, ACHA as far as, recommendations and, what other universities are doing.
Great. I have time for one more question, and people have asked about immunization compliance in states that require immunizations. We're seeing in Massachusetts, at least, people are not getting their immunizations, even children, because of being afraid to go to their healthcare provider. So colleges are very involved in this process come when students get back to school. Dr. DeMaria, will there be any kind of allowances for compliance?
No, I think we're very much aware that a lot of things aren't happening that should be happening, including vaccination. And I think we need to, and there's ongoing discussion now about how to handle that when the school year starts. And I think I don't have an answer to that, but it's definitely a big concern of immunization programs around the country.
Great, thank you so much. I'm going to
Jerry?
pass this over to Robin.
Oh, Angie, did you want to pipe in there? Because you're.
Yeah, I was just going to add that we are certainly watching that as well at the University of Oregon. We have enforcement that happens at the end of the term, and so we realize that we are going to have to staff up considerably on immunization. Thank you.
Great, thank you. Well, unfortunately, we're at the end of our time today, but I want to thank everyone for being here. I want to thank our presenters for their incredibly valuable insight. Thank you, Jerry, for moderating today. I know that there were a lot of unanswered questions. Like I said, we're going to look at all those questions and try and address them. We will also try to address those in our guidelines that are coming out soon. And our Q&A will be back on May 15th. Please continue to share your ideas and questions and solutions in ACHA Connect. And in the meantime, stay safe and be well. Goodbye, everyone.